Hey guys, this is a review of lecture 19 through 20 for physio, blood pressure regulation and cardiovascular integration. We're going to be looking at the body's feedback control mechanism to maintain blood pressure in a variety of situations. And so the basic idea is that the body uses negative feedback control in order to maintain blood pressure. Specifically, we use baroreceptors, pressure sensors, and then chemical receptors for oxygen and carbon dioxide to determine what's going on with blood pressure, specifically baroreceptors. That information goes to the central nervous system, our integrator, and then based on the information from the sensors, it's going to send instructions to our effectors, aka to do muscle dilation or contraction to maintain blood pressure or increase heart rate, etc. Okay, so the baroreflex is really what we're focused on, at least initially. It's controlling blood pressure on a short-term basis using two main classes of baroreceptors. We have the arterial baroreceptors, which are located in the walls of the carotid sinus and the aortic arch. So it's here and here. We know that coming off of the aorta, we have the common carotid arteries eventually. And so our baroreceptors located there, and then our aortic arch has the arterial baroreceptors. And then the second class of baroreceptors are our cardiopulmonary baroreceptors, which are located in the heart, the atria and ventricles of the heart, and then the pulmonary vessels going from the heart to the lungs. And so these baroreceptors in general, they're being stimulated by stress. And then the question is, at what point do you have stimulation along the nerve to the vasomotor center. And so the idea is that the baroreceptors are going to be silent until a certain blood pressure is reached. And so our baroreceptor nerve activity is going to be silent until you get to a threshold. And then after you've reached the threshold pressure, as you continue to increase the pressure, you're going to have more and more stimulation of the vasomotor center, more and more parasympathetic nervous system stimulation, and that will increase until you reach a particular temperature, at which case, or particular pressure, at which case you've reached saturation, and you're not going to have any additional baroreceptor activity. You'll still be firing, but it's going to max out overall. All right, then you have the whole nerve activity. So the idea is that you have a number of different baroreceptors, but the two main classes, we said we had arterial, and then we had cardiopulmonary baroreceptors. The ones that are located in the carotid sinus are going to be connected to the glazopharyngeal nerve, which goes to the vasomotor center integrator, and then the baroreceptors in the aortic arch and the cardiopulmonary baroreceptors are going to travel along, send their information along the vagus nerve to the vasomotor center. All right, but the idea is that there is, as blood pressure increases, overall the threshold for more and more of our baroreceptors is reached, and then you can reach a saturation point, in which case you've gotten to such a high blood pressure that you've gotten to maximum stimulation of the vasomotor center, maximum parasympathetic stimulation. All right, so that's what this slide is really saying. The glazopharyngeal nerve and the vagus nerve going to the vasomotor center. And so really what we're trying to say is that the vasomotor center is serving as an integrator, is taking in this information, and then it's going to send out information to do something about it. So vasodilating or vasoconstricting or increasing heart rate overall. And so first thing to look at, this is a nice diagram given to us in lecture. In the normal situation, you can see that there's a tonal or continuous activation of our baroreceptors. That's what these little dots, dashes are supposed to represent. And so that's our normal situation. If you are in a case of lower blood pressure, then you have less stimulation of the baroreceptors. You haven't reached as many thresholds on individual baroreceptors. And so what's going to happen is that if you have lower blood pressure, less baroreceptors are being stimulated. Therefore, you have less parasympathetic nervous system stimulation. And as a result, you're going to get a corresponding increase in sympathetic nervous system stimulation. And so what that means is if sympathetic nervous system stimulation is going up, you're going to have an accelerated heart rate, the contractibility of the heart, so increasing strength of contraction is going to go up, and then you're also going to have vasoconstriction based from the sympathetic nervous system. All right, the opposite is true is if you have if you have higher blood pressure, you're going to cross the threshold of even more baroreceptors, and so you can see we have even more stimulation of those baroreceptors, in this case along the glazopharyngeal nerve, and so the result is you're going to have more parasympathetic nervous system stimulation. Parasympathetic nervous system does vasodilation. It also acts on the AV and SA nodes, and it's going to slow down the heart rate and decrease strength of contraction. All right, so then if the vasomotor center in the central nervous system is taking information from the baroreceptors, that's the general theory. What happens in the specific case of, say, you are losing blood pressure due to, say, loss of blood? So hemorrhage is loss of blood. How does the body respond in the short term, and then we'll get the long term to blood loss? All right, so very conceptually, we have, if you are losing blood, there's going to be less input to the heart, right? So the venous return is going to go down. Preload is the stretch on our right atria at the end of distal, right before systole contraction. So preload is going to go down because you just have less blood in your atria. The stroke volume is going to decrease because you have less blood, less preload in the ventricles. Then as a result, your cardiac output is going to decrease. As a result of that, your arterial pressure will be decreased. You'll have, as a result of that, less firing of the baroreceptors because the pressure is decreased, you're not meeting the threshold. That means that you're going to have less inhibition to the vasomotor center, aka less sympathetic inhibition, right? Constantly parasympathetic is being stimulated because the baroreceptors have a sort of a tonic level of, in normal circumstances, you have continuous firing of baroreceptors. And so if you're lower, and that continuous firing is inhibiting the sympathetic system activity, and so if you have less firing of baroreceptors, you're going to have less inhibition of sympathetic, you're going to have less parasympathetic activity, so more sympathetic, less parasympathetic activity. Sympathetic activity we know is going to increase heart rate based on the previous slide. It's going to increase contractibility, aka inotropic state, and the result is you're going to have an increase in cardiac output due to this increase in sympathetic activity. We also know in the vessels that the neuroepinephrine neurotransmitter is going to act to increase total peripheral resistance by causing contraction. If you have total peripheral resistance, right, more vasoconstriction, you're going to get less venous volume in the rest of your extremities, and so the result of this is you're going to force blood to go back centrally, to the heart, and that will increase the preload. And so the idea is we went from decreased preload to increased preload with more sympathetic activity. All right, so what about the long-term response? Well, long-term response is going to use hormones, right? And so basically the setup is the same. Blood loss means less venous return, less pressure on the atrial wall before contraction, then less stroke volume, less cardiac output, less arterial pressure, less baroreceptor firing, less inhibition to the vasomotor center, which means less inhibition to sympathetic activity, which means more sympathetic activity. Then the increased sympathetic activity is going to stimulate the kidney to release renin. Renin will convert angiotensin to angiotensin 1. Angiotensin 1 will be converted by angiotensin 1 converting enzyme, aka ACE, to angiotensin 2. So an increase in renin means an increase in angiotensin 2. Angiotensin 2, angio, blood vessel, tension will mean we have an increase in vasoconstriction. Increase in vasoconstriction means increase in peripheral resistance. And you'll have a greater capillary fluid reabsorption. That means that total blood volume goes up. Then why would you have greater capillary fluid reabsorption? Well, peripheral resistance has gone up. That means that the blood pressure in the capillaries has gone down, at least initially, and so you have more absorption forces, like Starling's equation, and then you're going to get an increase in blood volume. Angiotensin 2 will also stimulate the release of aldosterone from the adrenal glands, which should top the kidneys. Aldosterone is going to increase sodium and water retention, and that will also increase blood volume. And then you have inhibition to the vasomotor center is also going to increase vasopressin, released by the pituitary gland. We like vasopressin because it's pressin on the vasos, right? It is a vasoconstrictor. All right, so vasopressin is released by the pituitary glands, and the net result is for the kidney, you're going to have an increase in water retention, so less peeing, and blood volume will go up. Blood volume goes up means more venous return, increased preload, increased stroke volume, increased cardiac output, increased arterial pressure. All right, so the idea is that a lot of blood loss, and then eventually we get back to normal. All right, so those are all baroreceptor discussions. Now we'd like to talk about chemoreceptors. And so chemoreceptors are sensors, afferents, that will send nerve signals in response to changes in blood oxygen and carbon dioxide content. And so we know intuitively, right, we want to maintain in our arterial system a high O2 content such that the tissues in the body can use that, right? And carbon dioxide is a waste product we know from the citric acid cycle, from glycolysis. So high carbon dioxide levels, high waste in our blood is bad, right? And so our chemoreceptors are basically on the lookout for, in particular, high carbon dioxide content. And so we have these nice graphs from our lecture, but basically what they're saying is that the chemoreceptors that are located at the carotid sinus or along the aortic arch are very sensitive to small changes in carbon dioxide in the blood. And so what they're going to do is increase vascular resistance greatly with small changes in carbon dioxide. Again, why would you want to change vascular resistance if you are having more carbon dioxide circulating? Right, the idea is that theoretically something's gone wrong, you're going to want to shunt blood back to the organs where they are most needed. All right, and then over here, the idea is that you need a large change in oxygen content before the same effect will happen, but a small change in carbon dioxide, and you'll get a large change in system vascular resistance. All right, and that's what this is saying here. All right, so then we have something called, also with these chemoreceptors, we have Cushing's reflex. And so Cushing's reflex has to do with when the brain is swelling. So say you have you've been hit in the head, and your brain's been hit and it's swelling. And so if your brain's swelling, this is going to increase the tissue pressure that's acting on the blood vessels in your brain. And so overall, right, the point of using our blood vessels is to deliver oxygen and remove waste, and so deliver nutrients, remove waste, and so it relies on perfusion pressure to do this oxygen delivery. And perfusion pressure is defined as the pressure from our arteries pushing outwards minus the pressure of our tissues pushing inwards. And so we need to maintain this perfusion pressure to make sure our brain is getting what it needs, the oxygen. And so basically, what's going to happen in Cushing's reflex is that the chemoreceptors are going to see that the O2 in the blood has gone down, and as a result of O2 has gone down as a result of the tissue pressure. The tissue pressure has gone up initially with no initial change in the arterial pressure. And so if P tissue goes up initially, this one hasn't changed yet, then perfusion pressure is going to go down, and then O2 will go down. All right, and so Cushing's reflex is meant to fix this. And so how does it go about fixing this? Well, we've sensed that there's a problem. We're not getting enough oxygen to the brain. So we're going to spike the arterial pressure to try and maintain the perfusion pressure. So if P tissue has gone up, we need to increase the arterial pressure to maintain perfusion pressure such that O2 can be delivered to the brain. All right, so not that bad. And so we have O2 is sensed by our central chemoreceptors. You stimulate the central nervous system to vasoconstriction, and then the net result is you're going to get blood to the brain by maintaining our perfusion pressure. All right, so cardiopulmonary baroreceptors, and then also we have our hormone released by the ventricle and atria of the kidney. So we have a couple of things going on here. We have atrial and venous baroreceptors act in the same fashion as the arterial baroreceptors, but are more sensitive to change in blood pressure. Hemorrhage results in increased sympathetic response, aka vasoconstriction and increase in heart rate. The ventricular receptors, aka C fibers, will do the same thing, but they can induce something called the vicious cycle of hemorrhagic shock, which we'll get to in a second. And then also, changes in blood pressure will be felt by the atrial and ventricular myocytes because they will get stretched, right? They're making up the walls of the ventricles of the heart and the atrium of the heart. And so in the atria, you have this atrial natriuretic peptide that is released by the atrial cells, the myocytes, when blood volume increases. And this goes to our kidney, which results in increased peeing, elimination of sodium ions and water. And then brain natriuretic peptide does the exact same thing. It's released by ventricular cells in response to that stretch due to high blood pressure. And why is it called brain instead of ventricular? Because it was first discovered in the brain. Okay, so what is this vicious cycle of hemorrhagic shock that can be induced by the ventricular baroreceptors? So the idea is that if you are bleeding out, you have a lot of blood loss due to hemorrhage, what you can have happen is severe blood loss will result in high circulating catecholamines, especially neuroepinephrine, and an increase in sympathetic activity, fight or flight. The sympathetic activity increase, as well as the epinephrine concentration, and a low preload, aka the blood pressure at the end of the diastole phase, can activate our ventricular baroreceptor C fibers. And since these travel along the vagus nerve, they are going to activate the peripheral nervous system and inhibit the sympathetic nervous system, and this is going to cause an increase in bradycardia and peripheral vasodilation, which is bad because, right, we want to make sure that our organs are getting the blood that they need in hemorrhage. And so if we're doing peripheral vasodilation, we're allowing blood to be maintained in the rest of the body, and so our organs are going to get ischemic, aka not enough oxygen, and they're going to bleed out. And so and then these C fibers are causing this cycle of hemorrhagic shock by activating the peripheral nervous system. All right, and so, as a result of the activated peripheral nervous system, you're going to have decreased cardiac output, result in decreased blood pressure, decreased tissue perfusion. Your tissues aren't going to get enough oxygen. We know from the citric acid cycle or glycolysis that, there's the oxygen-independent pathway, which will produce lactic acid. And so the tissues with loss of blood are going to, and not enough oxygen, produce a lot of lactic acid, and therefore that buildup will cause acidosis. And then acidosis is going to further depress cardiac function, and then the reactivity of the vessels to the sympathetic nervous system, which would constrict the peripheral vessels and, help alleviate some of these issues. And then finally, the third thing that can happen is you can have depression of the gut-brain barrier and depression of the reticuloendothelial system, which is the macrophage system around our gut. And so this can lead to an invasion of the circulation by bacteria normally present in the intestinal flora, and then that will lead to an accumulation of endotoxins, which may further depress cardiac function and circulatory homeostasis. All right, so basically, hemorrhagic shock, a lot of bleeding out. The ventricles, receptors, the C fibers, can do stimulation of the peripheral nervous system and cause vasodilation, bradycardia, which is not good. It can also be stimulated, the C fibers can also be stimulated by not enough oxygen. And then acidosis can result, which makes things worse, and then you can get endotoxins from reduced or depression of the gut-brain barrier and macrophage response. All right, so then long-term control of blood pressure. Basically, the core premise is if you have long-term increased arterial blood pressure, short-term response, we have barrier reflex, but the long-term response is really just to increase your urine output, and so that if you pee more, the fluid volume is going to decrease, aka blood volume is decreased. If blood volume is decreased, your cardiac output is going to be decreased, and your arterial pressure is going to go back to roughly normal levels. So long-term control, the thought is you pee a lot more. All right, then one last thing on this particular lecture was orthostatic intolerance, and so this is aka the inability to stand upright without fainting. So if you're laying down for a long time, the idea is that these same C fibers that cause the vicious hemorrhagic cycle can become activated if you're laying down for a long time, and this is because of this abnormal contraction pattern when you have high contractility but preload is high due to your laying down. You have low heart rate, central blood volume is high, and so this will result in we know that the C fibers will activate our parasympathetic nervous system, causing bradycardia, and the inhibition of peripheral sympathetic vasoconstrictor activity. This results in decreased cardiac output and peripheral vasodilation, and as a result, the arterial pressure is going to fall, and therefore your perfusion pressure is going to decrease. And so this is all laying down, and then when you stand up, you notice that for this little graph here, standing up, your arterial pressure is actually going to go down, right? Because if you're standing up, blood has to go vertically in your heart, vertically through your body to get back to your heart, and so you'll have a decrease in your right atrial mean pressure. As a result of less central blood volume, your arterial pressure goes down, and so if you stand up quickly after laying down for a long time, then it's going to exacerbate all these the problems derived from the increased PANS activation, this lowered perfusion pressure, and so you will not get enough oxygen to your brain and faint. That can happen. All right, so we're about hopefully a little bit more than halfway done. The second lecture was about exercise and the response to exercise, and so basically the normal response to exercise is increased heart rate, which you can see this little graph. Stroke volume increases a little bit, but we have our cardiac output really from the increase in heart rate. Blood pressure is going to go up. Again, this is the normal response. Total peripheral resistance is actually going to go down. Right, our sympathetic nervous system is going to vasoconstrict all of the unnecessary things, right, your gut, kidneys, but your generally the vessels in your skeletal muscle are going to vasodilate. All right, oxygen consumption goes up, right, due to increased metabolic demand, and then the difference in oxygen content in your arteries versus oxygen content in your brain is going to go up, aka there's less oxygen content in your veins due to it being used, more of it being used. Right, so that brings to the concept of oxygen consumption during exercise. In a normal situation, aka non-exercise, only about 25% of the oxygen in the blood is being used by most tissues. This is not true in the case of heart, which uses most of it. And so if we want to increase oxygen consumption, we can do one of two ways. One, by increasing blood flow, because there's a lot of oxygen still left in our veins, because only 25% of it gets used normally. Or you can increase the extraction of the O2 in the blood, or you can do both. And so for the heart, generally, as we see we go from rest to higher exercise, we can see that the venous O2 content is decreasing, arterial oxygen content increases a little bit, and then the veins of the heart, the coronary veins, aren't having a big change in O2 because they tend to use most of the oxygen already. All right, so oxygen consumption, we can quantify it with an equation as flow times extraction, so that's cardiac output times the difference in arterial minus venous O2 content. And again, skeletal muscle increases O2 extraction in response to dynamic exercise. Cardiac muscle doesn't increase extraction much. It's more flow dependent, but you can increase oxygen to the heart through increased flow. All right, and then what's going on if we are dealing with somebody who is maybe a little bit healthier than normal versus somebody who has mitral stenosis, which is a disease narrowing of the mitral valve orifice. For a professional athlete, we're given this diagram. Basically, compared to normal, when they exercise, their cardiac output increases. their stroke volume increases, their resting heart rate compared to a normal person, not during exercise, but generally, professional athlete has a lower resting heart rate. They require a greater workload, right? Maybe running faster to increase their heart rate significantly. They have a greater difference in atrial versus venous oxygen content. And then when they exercise, there is a decrease in blood flow to the organs of the GI system and the renal system. And then there's a predicted increase in concentration of neuroepinephrine, aka systematic or sympathetic nervous system. All right, and then for somebody with mitral stenosis, narrowing of the mitral orifice compared to normal, a normal person exercising, they have decreased cardiac output, decreased stroke volume, right? There's something wrong with their bicuspid valve. Their heart rate when they're resting is elevated, and they require a lower workload to increase their heart rate. While exercising, they do have, just like usual, the increase in difference between arterial and venous oxygen content. And then like usual during exercise, the blood flow to their gut and their kidneys is decreased due to vasoconstriction from the sympathetic nervous system, and they also have an increase in neuroepinephrine because the sympathetic nervous system is being more activated. All right, and so that brings us to a little bit more about cardiac output. The idea is that if you are exercising, right, your muscles are going to need have more metabolic demands, and so the cardiac output, the flow to the muscles should increase. Same with flow of blood to the heart, the coronary arteries should increase as well, and then you're going to decrease the output, the flow to the kidneys, liver, and GI, because it's not necessary for running, right? And so it's like a fun thing for people deal with runner's gut if you're into running, or you just have had a long time of lack of blood to your gut, and then when you stop running, that blood returns, and then you feel an activation generally of your the pain sensors in your gut as a response of that shift in blood content when you're done exercising. All right, so mechanisms that mediate this response, now that we know what the response is, right? Increased heart rate, stroke volume about the same, cardiac output increases, blood pressure increases, peripheral resistance decreases, right? You want to vasodilate in the skeletal muscles, oxygen content should increase. What is actually causing this to occur, right? So the general idea is parasympathetic activity should decrease, sympathetic activity should increase, and we have three mechanisms that we think are generally occurring. One is central command, so the desire to exercise means that you're doing more like voluntary muscle movement, right? And so the autonomic system, aka parasympathetic, sympathetic, is the automatic system, right? If you're doing more voluntary, the involuntary stuff will decrease. And so that's the first theory. Central command will decrease the autonomic system, but this is really only acting on the parasympathetic autonomic nervous system. The sympathetic doesn't really change that much. Then two, you have the arterial barial reflex. And so the idea is that in exercise, since blood pressure increased, it's thought that the baroreceptor would fight against this, the reflex. But what happens is there's a reset to a higher level for triggering of the barial reflex, such that you don't get, right, barial reflex is going to say blood pressure is too high, let's activate the parasympathetic nervous system and get to rest and digest, and that doesn't happen during exercise due to a reset in threshold. The mechanism is unclear, we don't know exactly what it is. All right, and then finally, the third mechanism has to do with skeletal muscle, and so the idea is that you have metabolic receptors and then mechanical receptors, and so the idea is that for metabolic receptors, as you start to exercise, you're not getting enough oxygen to the skeletal muscle, and so you have metabolites, potassium ion, lactate, carbon dioxide are going to accumulate, and that's going to stimulate group 3 and 4 afferents, basically stimulate some nerves that are going to increase heart rate and arterial pressure, so through the SNAS, sympathetic nervous system, and then this is why you often have large increases in arterial pressure with patients with peripheral vascular disease, because if you have limited blood flow in peripheral vascular disease, then you're going to have this accumulation of these metabolites, which are going to stimulate these afferents that are going to stimulate this sympathetic nervous system and increase heart rate and arterial pressure. All right, mechanico-reflex. Before we move on, the metaboreceptors have little control of the parasympathetic nervous system, but they stimulate the sympathetic nervous system. They can also stimulate vasopressin release, which constricts vessels, which would be constricting vessels in the gut and kidneys. Then mechanico-reflex is basically the same sensory nerves that were stimulated by this increase in concentration of metabolites, can be stimulated by muscle stretching or contracting, and this will increase heart rate and arterial pressure. All right, and then so that's this final thing. Graded exercise. Graded exercise is defined as exercise where you're gradually increasing intensity, and the idea is that response to graded exercise is that at the start of the exercise you have a rapid decrease in the parasympathetic nervous system, slight increase in sympathetic nervous system, and then as you increase the intensity of the exercise, the parasympathetic nervous system activity is going to basically go to nothing, and the sympathetic nervous system increases dramatically. All right, whole body exercises. This is like running, swimming, doing burpees. Basically, whole body dynamic exercises are the sympathetic. We're saying basically we've already said the sympathetic nervous system is going to increase activity in the inactive beds, the kidney, gut, skin, to cause vasoconstriction, because you don't want your blood going to the digest stuff, right, if it doesn't need to. You want the blood to go to the skeletal muscle where it's needed. However, one of the interesting things is there's also stimulation, some vasoconstriction that occurs in the skeletal muscle. We said generally sympathetic is doing vasodilation in the skeletal muscle, but it can also do vasoconstriction. So you have these two, vasodilation and constriction occurring. And so the question is, like, why would that occur? And so the idea is that there's, if you were to have maximal blood flow, complete vasodilation, you have this ability for that max blood flow to be this huge number, 3,000 milliliters per minute per kilogram of muscle, right? And for persons like 50 kilograms of muscle, this is a very big number. So if the average person is exercising only half of their muscle mass, maximally exercising half of muscle mass, then the blood flow is theoretically, it would be 45 liters per minute. However, the heart is just not capable of producing that much blood flow, so you need some vasoconstriction from the sympathetic nervous system. It can't just be completely vasodilation. All right, so a quick thing about dynamic isotonic exercise, running versus swimming, versus isometric, aka weightlifting. For isotonic running and swimming, the mean arterial pressure increases linearly. For isometric, there's a huge initial jump in mean arterial pressure, but gradually decreases with time. All right, and then hypothermia is important to discuss. Basically, when you're overheated, the majority of the cardiac output is directed to the skin due to via an increase in cardiac output and redistribution of blood towards the skin. You're having a lot of vasodilation via activation of the sympathetic active vasodilator nerves. So generally sympathetic activation is doing vasodilation, but for the skin, it will do sympathetic is generally doing vasoconstriction, but in the skin, it will do vasodilation. All right, so basically the premise is that as skin temperature increases, you're going to have a large increase in blood flow to that region, less blood flow to the the gut, the kidneys, and the muscles, because so much of it is going to the skin. And then as a result, you have there's also, if you have less blood flow to the muscles, you're going to have, I think this is a typo, you'll have a decrease in mean arterial blood pressure because so much of it's going to the skin, decrease in, for the same reason, right atrial mean pressure. Stroke volume will go up, but the net result of this decreased pressure is you're going to have less perfusion pressure, and then you could potentially have fainting. All right, so that's it. That was super long, but we're done with physio for this unit, and we'll see you next time.